Hello everyone. It is my honor to present to you the inaugural post of the Procedures section on the Critical Care Now platform. I'm your host, Harman Gill. COVID-19 has changed so much of what we do at work, and procedures are no different. As frontline providers, it is now more imperative than ever to not just efficiently do procedures, but to do them safely. And in this procedural mini-series, we thought that we'd focus on providing our proceduralists and our entire teams certain tips and essential improvements to keep you safe, your team efficient, and of course your procedure successful. In this first post, we will focus on the 5 P's of the COVID airway. We have a series of domains we'll talk about, and without further ado, let's dive right in. In the preparation, this is of paramount importance because, by definition, intubation is an aerosol generating procedure. We need to pay close attention to the rooms and the location of where we intubate these patients. These rooms need to be negative pressure rooms. These rooms need to be in close proximity to the donning and doffing stations. The rooms, if you're in the ED, need to be in close proximity to EMS entry hallways. If you're in the ICU or in the ED, you need to have special attention paid to the PICSs, where the ventilators are kept, where the respiratory equipment is kept, so that everything that you do need is readily and freely available. Airway bags. The key word here is to be portable. We have all gotten so used to our nice airway towers or being able to have supplies go in and out of the room at the drop of a hat. But here, whatever goes into the room cannot then come out, is not something that you can reuse, and anything that goes into the room should be considered contaminated. So pay close attention to take everything that you need, whether it's plan A, plan B, but it has to be in a portable fashion to keep you set up for success. Checklists. These are also important not just for the proceduralist to be very systematic, but also for your entire team, and to make sure that everyone from nursing to RT has what they need. Here's an example of our airway bag, and essentially when we decide that it is time to intubate someone, we pick this up and we back ourselves up that it has everything that our nursing staff, our RTs, and our airway operators need. We've made specific revisions and modifications to even the EMR with a one-stop shop for all the induction medications, vasopressors, and analogous sedation medications, the providers. It is always important to have a clear leader to the resuscitation team, but within the COVID-19 realm, there are many hospital-based COVID airway teams that exist in complement or in addition, and sometimes even in replacement to the regular airway teams. I'm not here to tell you that one is better than the other, but we know that in times of surge and high acuity, one person should be able to interchangeably and reciprocally do the other person's job. So don't feel false confidence or feel overtly safe in the COVID airway team being able to manage and handle every one of your airways. You should also know how to go about safely and effectively performing these procedures, and thus it comes down to the clinical pearl of the fact that the provider doing these airways should be the most experienced operator. Not the most senior operator, but the most experienced operator. Pre-oxygenation. We support and wholeheartedly recommend the high-flow nasal cannula system. I'm not paid by the company, but it is most safe when started at 40 liters per minute, 100% FiO2, and once the interface is working and in place, to place a level 2 surgical mask over it. I won't belabor the data of why it is safe, but it is able to safely deliver high FiO2, it is able to help with the work of breathing, and it also, with the placement of the level 2 surgical mask on top, prevents further spread of aerosolized particles. If for some reason you must use an NIV interface to pre-oxygenate, make sure that you have the HME filter in place, and make sure that you connect it directly onto the ventilator so as to not contaminate one more piece of airway equipment, the BVM. The setup is of crucial importance. You have your mask, that becomes in series with your HME filter, that is in series with your end-tidal CO2 cannula, and of course, finally, is in series with the PEEP valve and your airway bag hooked up to a high reservoir of rich high FiO2 oxygen. When Using the BVM, we recommend a two-hand mask seal technique, and to ensure, of course, that the patient at baseline is shaved and has good contact, and everyone that is in the room, whether it's respiratory therapy or the actual airway practitioner, is wearing the appropriate PPE and is in the appropriate negative pressure room. The performance. Here's another sample of our own intubation checklist, and we make sure that please note, before you enter the room, we have all checked the appropriate compliance with PPE within our team. The nurses make sure that there's an adequate weight and height, calculate the predicted body weight, and ensure that all our meds that we intended are actually drawn up and ready to go. Our respiratory therapists do the same and ensure that the clamps, the BVMs, the HME filters, and the ventilators are either inside the room or outside the room, and the team is aware of every portion of it. The airway operator themselves ensure that they have what they need, but the key thing that they're going to perform is definitively RSI and use video laryngoscopy as their go-to method so as to decrease the spread of aerosolized particles from the hypopharynx to the patient, as VL allows the airway operator to stand a little further back than the comparative position in direct laryngoscopy. Ultimately, it comes down to practice, and we recommend practicing in the in situ simulation fashion. We have tried and tested certain scenarios where our teams have expressed difficulty. We take a mannequin, we put it in a room, we set up a scenario, get the entire team in situ to not only just practice and perfect what works, but iron out the kinks where the system breaks down. And ultimately, these debriefs are also a fantastic opportunity to address the stress, the anxiety, and the wellness of your entire team. With that, I close and tell you that in summary, here are the 5 pearls for the next COVID positive or the COVID suspected airway that you will need to undertake. We start with preparation, the appropriate airway bag that is portable, the appropriate room, and the appropriate PPE is available and used. The provider needs to be the most experienced provider. Pre-oxygenation is recommended through the high-flow nasal cannula system. Use a level 2 surgical mask on top of the interface. And if you must use the BVM, use a two-hand technique with an HME filter. The airway operator ensures that they and their entire team have everything that they need before they enter the room, that they use RSI, that they use VL as their go-to modality for laryngoscopy, and that everyone speaks and focuses in closed loop communication. And you practice all of these things in situ simulation and address the positives and the negatives and address the overall wellness and performance efficiency of your team.